I am one of the oncologists at Cincinnati Children's, a pediatric oncologist by training. I have been at Cincinnati Children's for just about 11 years now. And I first developed my interest in fertility preservation and oncofertility during my fellowship training prior to coming to Cincinnati. I was very excited to find the program in Cincinnati Children's and be able to collaborate with our adolescent gynecology division to help build the program into what it is today.
Hi, and I'm Holly Hoefgen. I'm new faculty here at Cincinnati Children's. I've been here for a little over a year. I'm a gynecologist by training with additional fellowship in pediatric and adolescent gynecology, and was very lucky to start with the program here in the fertility division when I became faculty in the pediatric and adolescent gynecology department. We are hosting tonight's event because we've been hearing from our families that there's a high interest in understanding more and more about what effect their child's treatment has on their future fertility and on their reproductive potential in general. As both of us have a high interest in this area, then we are here to kind of explain to you a little bit about our program, about what's available, and about how this affects your children in general and you as patients. So just to explain a little bit about our program, Dr. Burns started this program with one of our previous gynecologists several years ago with just a small limited number of options for patients, and it's grown into what is one of the top-notch programs in the country, where we're able to offer several options to patients. We're a large multidisciplinary team that obviously involves gynecology, oncology, also urology, but also a large team that assists us from nursing and ethics, as well as quality improvement, and a huge team that's just numerous, where we're able to help both boys and girls from infancy all the way up to adolescence and young adults. And we make it our kind of motto to make sure that we see every patient that comes through the Cancer and Blood Diseases Institute at this point, no matter what their risk factors are, because we feel that it's important that every patient knows what their risk for future fertility issues is, even if that risk is small, so that they get to hear about these things and know what options are available.
So Dr. Hoefgen and I are going to try to field questions from you and answer as many as possible. Feel free to start typing in your questions and we'll get them queued up to answer. So as you're thinking of your questions, please enter each question only once and we will get to it as soon as we can.
All right, so it looks like we have our first question here. So Dr. Burns, our first question is, what is oncofertility and why is it so important that we feel like we need to do this whole chat today?
So oncofertility is really the marriage of cancer therapy and fertility preservation. So we have learned over the years that certain therapies to treat cancer pose different risks for future fertility, and that is different between males and females, and it's a little dependent on your age. As the success rates of cure in pediatric cancer have continued to increase over the past several decades, we've really begun to think about the future and getting back to a life that is as normal as possible with as many possibilities as we can, even at diagnosis. So one of the things that we feel is really important is preserving a child's ability to have their own children in the future once their cancer therapy is finished. It looks like the second question is, how do you calculate my infertility risk?
I think that's a good question answered by our oncologist.
So basically we have two oncologists on our team, myself and one of my colleagues, Dr. Phillips, and we calculate the infertility risk based on the individual therapy for any given patient. So we take into account obviously the underlying diagnosis, but also the therapy that it's going to require. So we look at the different chemotherapy as well as how much of each individual chemotherapy agent is going to be used. In addition, we also take radiation into account and the location of the radiation along with the dose. And we kind of put all of that together to come up with an individual risk for a patient, and we categorize them based on low risk, which is less than a 20% chance of a fertility problem down the line, intermediate risk, which is between 20 and 80% risk, and high risk, which is someone who would have a greater than 80% chance of having fertility problems once cancer therapy is finished.
And I think what's good with that is then once with our team, we try to utilize everyone's strengths, right? So once our oncologists on our team are able to tell us what is this patient's infertility risk, then us as the providers who come and talk to you about your future risk of infertility can take that and then use that to give you options for whether you would like to talk about fertility preservation, or at least just give you an idea of, what does the future hold, or, can I think about what the future holds as far as my risk?
Okay. It looks like our next question is, I had cancer when I was 2. Does that mean my fertility will not be as affected since I was so young? And the answer to that, the short answer is it depends. It depends on a couple of different factors. So one is males versus females. So young girls, anyone who's not gone through puberty yet, is relatively protected from the effects of chemotherapy. So it would take much higher doses to potentially cause a problem with fertility down the line. Boys, on the other hand, remain at risk even when they're younger. So it's possible that a boy who was 2 years old may develop problems with fertility down the line. And again, like we said earlier, that's going to depend on the therapy that was received. So if they received significant gonadotoxic therapy, or therapy that was toxic to the testicles or to the ovaries, then they may be at risk down the line. Many patients who received therapy at the age of 2, though, are not going to have any risk to their fertility. Okay. The next question I'm going to throw over to Dr. Hoefgen, because I think I've talked enough for the moment. Is there a blood test that can assess my fertility?
All right, so that's a very good question, and that's another one of these questions that kind of depends, right? So we'll start with talking about this question basically for females, because there's a little bit more to talk about in this instance. So to talk about blood tests that affect fertility, initially we talk a little bit about the female reproductive system and hormones and how that works, right? So if you think about the female reproductive system, there's signals that come down from the brain that talk to the ovary, right? And those signals, normally we talk about something called follicular stimulating hormone, which is a hormone that tells the brain, tells the ovaries how to function, right? And then your ovaries at that point would produce estrogen. Commonly, this is the hormone that we've used to decide if everything is functioning correctly, right? Because if that signal is really high, then it says the ovaries aren't really doing what they're supposed to do. So we say kind of the brain starts yelling at the ovaries. So if that level's high, then you know the ovaries aren't really functioning well. It hasn't been the best test, because usually by the time it's elevated, then the ovaries already aren't doing their job. So we find that that is kind of a late marker, right? So we started looking for something that could maybe give us an idea a little bit earlier. So now we look to something called anti-Müllerian hormone, which this gives us an idea of the amount of eggs that you might have on reserve in your ovaries. So a female gets the amount of eggs that they're going to have when they're a fetus before birth. When you're born, you have all the eggs that you're ever going to have, and it tends to decline throughout life, right? So this anti-Müllerian hormone, although not perfect, and we're still learning a lot more about it, is very promising to give us an idea of what your fertility might be, right? So we're hoping to be able to use that to be able to tell us, was there a lot of damage from your treatments? Do you have a fertility potential that's remaining? And we're starting to use that quite often in those instances. So you'll hear us talk about that in fertility preservation consults, both before treatment and after treatment, as a way to assess the damage to the ovaries or the amount of fertility potential remaining. But it's still something that we're testing a lot, so it's not a perfect system, but it's something that we can utilize. As far as blood tests in males, there's really not a test of fertility for a blood test of fertility in males, unfortunately, at this time. In males that have already went through puberty, the best thing that we have to assess fertility is just getting a sample of the semen, right? So a sperm sample, and being able to test that and seeing the potential of the fertility at that point. We don't have a good option for males before puberty at this point to be able to utilize, but it's definitely something that science is looking into.
Okay. And the next question is, does insurance typically cover the cost of fertility preservation?
So I think, that's another tricky question. And a lot of it depends on what type of insurance you have and what state you live in, because these vary from state to state and from insurance to insurance. Some states have covered, that they mandate coverage for fertility, but a lot of these are if you have a diagnosis of infertility. So in patients who have already went through treatments, who may have an infertility diagnosis, then treatments may be covered. However, what we run into is a lot of times what we're trying to do is protect fertility before it's an issue, right? So unfortunately, in more times than not, we run into the fact where coverage is not provided because we're trying to protect fertility before you have a diagnosis of infertility, right? So even in patients who may have wonderful insurance that covers infertility treatments, you don't have that diagnosis, so the insurance coverage doesn't cover that. So in the vast majority of cases, it is not covered. We as a group who work in the oncofertility world are advocating strongly in the benefit of this and trying to, say basically that that's not fair and we want this to be covered, but there's a long road ahead to work towards that. So I would say at this point it's a case-by-case basis, and anytime that patients come through and are looking for treatment, we contact everyone's insurance companies. We're always advocating on basis of the patients to try to get those things funded, but in a large proportion, we unfortunately are not successful at that. But the good thing is that especially in patients with oncology type diagnoses, there are a lot of groups available that offer assistance with medications, assistance in storage fees for things like storing eggs and storing sperm and storing ovaries. So there's a number of programs that are helpful, and our team is very well used to working with these groups and making sure that we can get any assistance that's available for patients, that we can get that for them.
Okay. The next question is, are there options for fertility preservation after chemotherapy has begun? And are there any differences between boys and girls?
Right, so I think that's something we can both kind of tackle, because Karen also is the director of the survivorship program here at Cincinnati Children. So, we are working also to make a big impact in our survivor patients as well, because, oncofertility is kind of a newer program as far as new in the last 5 to 10 years. So there's a large number of patients who these treatments were not available, and we were not doing counseling when they went through their treatments. So there are a large number of patients where we're coming back after the fact and we're trying to counsel them and see if we can hit what we call kind of like this second window of opportunity to be able to talk to them about fertility preservation. So I think the short answer is yes, there are options. We just need to do some testing and see where where they are as far as fertility potential to talk about what those options are.
And I think there are certainly some differences between boys and girls in this area. Boys are at risk of losing their fertility with chemotherapy and then not regaining it afterwards. So the ideal situation would be that a male is able to sperm bank or freeze some sperm before starting therapy. Once therapy starts, we're not able to do sperm banking while you're getting chemotherapy. The one thing that we may be able to do is the testicular tissue cryopreservation, which is a research-based protocol that can be done after therapy has been started. Once males finish therapy, though, there's really not anything that we would need to do at that point, because again, going through therapy is when males are going to be the most at risk. So once the therapy is completed, if the fertility is still normal, there's no risk to it down the line. The girls are a little bit the opposite of that. So females are at risk of going into menopause early because of their chemotherapy. So a lot of our females will finish their therapy still with their fertility intact, but they're at risk of menopause earlier in life than would have been otherwise. So for our females, if they're interested in fertility preservation and not able to do it prior to starting therapy, they may be able to freeze some eggs or freeze some embryos after therapy completes, and take advantage of some fertility preservation in that way. I don't know if you have anything you'd like to add to that.
No, I think that's good. We're definitely working towards kind of increasing awareness in this population as well. Mm-hmm. So I think that's an important question to talk about too. Yeah. Okay. And then our next question that's coming through is, when is the best time to talk to your oncology team about fertility?
So I think ideally early on, before therapy starts. It gives us the most time to talk about the risk and to have the biggest potential for options out there. So we're going to have the most options available to us up front before therapy has started. And the sooner the better, because the bigger window of time you have before chemotherapy needs to start, again, the easier it is to get these things rolling. However, that said, any time is better than no time. So if it doesn't happen right away, or new questions come during therapy or after therapy, any time is absolutely an appropriate time to bring up those questions. There will be some questions that your oncology team will be able to answer, but they also know very well how to get a hold of us too if they don't know the answers to that, and they wouldn't hesitate to give us a call, and we could answer the question through them or be happy to stop by and give the answer in person.
Yeah. And I would say, and sometimes it takes more than one conversation. Mm-hmm. So, just because you had a conversation pre-treatment doesn't mean that you can't have a conversation again after treatment. So I would say early is always best, but there may be multiple times, and, we were always happy to talk to people as many times as is necessary.
And I think sometimes for oncology plans change along the way too. Mm-hmm. So the plan that we talk about in the beginning may not be the therapy plan that we carry out until the end. They change for any number of reasons along the way. And I think anytime your oncology treatment plan changes, your fertility risk may also change. So that's also another great time to ask the questions and to sit down with the fertility team to talk about what the current risk is for the future fertility. Our next question, if the patient is a minor, who will sign the fertility preservation consent documents?
Okay. So I think before we answer this, we probably should talk a little bit about what the fertility preservation options are, just in case there's people who aren't as familiar with this, right? So in our female patients, the options that we have available are ovarian tissue cryopreservation. So this is a usually laparoscopic procedure, so a camera that goes in through the belly with instruments that go, kind of along the hairline or the underwear line, and then one single ovary in most cases is removed. That ovary is then usually cut into small strips, which are frozen and then stored until the patient is ready to use them later in life. At this point, the majority of those cases, we're putting the ovary back into the body for it to be used for future fertility. But there's also testing for us to be able to use that tissue to create eggs and then do in vitro fertilization. But at this point, there haven't been any successful pregnancies using that. Also, in our post-pubertal females, then what people may be familiar with general fertility treatments is stimulating ovaries to produce eggs that can either be frozen themselves or put together with a partner's sperm to freeze an embryo. Okay. In our male patients, the options that we have available is what we call testicular freezing. Okay, so similar to the females where we removed an ovary, you can remove either an entire testicle or just portions, biopsy portions of a testicle. Now, both the ovary and the testicular freezing are both research protocols, okay, meaning that they're not standard of care, but they're things that have to be done under a research protocol. But we do make them available at Children's. So currently we do the ovaries at Children's. We are attempting now, where we should be doing the testicles at Children's within the next year, but we do make it available through an outlying facility at Pittsburgh for our patients, okay? And then similarly, we take the testicular tissue, we make small strips of those, and then those are frozen. There has yet to be a successful pregnancy from frozen testicular tissue in humans. There have been in monkeys, but that's because this is newer technology, and it's still, we're still working towards that in the scientific literature. And then what's obviously most commonly known, again from the fertility population in postpubertal males, is sperm freezing, right? So usually a sample would be collected, usually through masturbation, and then the sperm would be frozen for them to use with future partners. Okay, so now that we know kind of what the options are, the minor consent is going to be similar to what you would think of with any sort of procedure that you do with a minor, such as a surgery that your child may have for their treatments. If the patients are under 18, it would require that we have consent from a parent. If there are two parents that are involved, it requires that we have consent from both parents. Okay, but if your child falls into that adolescent age, then we also want assent, right? Assent from your child, basically showing that they understand the procedures that we're talking about, and that they also are a willing participant in this, right? That they're interested in having the procedure, that they understand what we're talking about, and that this is something that they also want to go forward with. So, and even in the patients where that assent process isn't required, I think, from our standpoint, we want to have both parents and the children involved at all times, so that everyone understands what's going on, and that, they know that we're there to kind of help them for the future.
Okay. Our next question is, I heard that reduced intensity prep for bone marrow transplant was not as harsh on fertility as a myeloablative approach. Is that true?
Do you want to take that?
Sure.
Favorite question.
So, so basically what the question is asking, there are two different approaches to doing a bone marrow transplant from a preparative regimen standpoint. So basically getting the body ready for the bone marrow transplant. So a more traditional approach has been the myeloablative approach, which is very high dose chemotherapy with or without radiation to completely empty the bone marrow of the host cells. Traditionally, that is associated with a very, very high risk of infertility, whether you are male or female and young or old. The non-myeloablative approach is slightly lower doses of chemotherapy and different combinations of chemotherapy, which can be used in certain situations, in certain underlying diseases. And one of the ideas behind that is that potentially, if you use lower doses of chemotherapy, the side effects, the late effects, will not be as severe as with the myeloablative approach. And fertility is certainly one of those areas where the hope is that the lesser doses will lead to less infertility down the line. I think the jury is still out on that. I think that the hope is there, but we're not really sure at this point whether or not it will really help to preserve fertility down the line. And it may be that it is very dependent on whether you are male or female and how old you are at the time of your transplant. So there's certainly active ongoing research in this area, so I would anticipate over the next maybe 3 to 5 years we would have more information about this, but I think right now we're just not sure, and so it's still an area where we would want to do everything that we can to preserve fertility prior to the transplant, and assume that we need to take all of those precautions.
Yeah, and I think at this point we still treat all bone marrow transplants as high risk. Yeah. Because we are one of the centers that's kind of looking into this, and we've seen some concerns for that still being a high risk treatment. So just with preliminary data, we treat that as a high-risk treatment. Okay, so our next question, for patients with newly diagnosed breast cancer, is it safe to undergo ovarian stimulation in the setting of hormone-sensitive disease? Okay, so this one, we don't tend to see as many breast cancer diagnoses in our institution because it's more of a pediatric institution. So some of this is going to be a little out of our realm, but just from the literature itself, there are a large number of breast cancer diagnosis patients who do undergo fertility preservation. And this usually would be done by our reproductive infertility colleagues in the adult world. And what they'll work very closely with the oncologists that patient sees to find more of a kind of a lower dose or a slower regimen to work with them and to see what both of them are more comfortable with. And some of this is going to be dependent on, the receptors, whether they're receptor positive and how many of their receptors are positive. So it's going to be a case-by-case basis, and it's going to be something where those physicians work together to decide what's going to work. But a large proportion of the adult population who undergoes fertility preservation are breast cancer patients, and a large amount of our literature that lets us know what to do in our population actually comes from the breast cancer literature. So I would say that the answer to that question is very reassuring, but I think a better answer would come from the adult population.
Our next question, for ovarian tissue cryopreservation, are there any diseases besides leukemia for which reimplantation of tissue is not recommended? So this is a great question. I think at the end of the day, it has to be an individual decision. The leukemia, the risk that this question, I think, is getting at is whether or not the last thing you want to do in the situation is to transplant an ovary or put an ovary back that has been contaminated with the original cancer cells. And so we worry a lot about leukemia because it's a blood-borne cancer. So we assume that the ovaries are contaminated with leukemia cells. So if you are taking an ovary from a patient who has leukemia, you would treat their leukemia and cure that disease. If you were to put that ovary back, you could potentially reseed that original leukemia and have a case of relapsed leukemia. And that's certainly absolutely something that we never want to do. I think anytime there's any concern that the ovary may be involved, then it would not be good to take the chance and replace that ovary. There are other potential options for using that ovary for future fertility. Off the top of my head, I don't think there are many other diseases, but there are certainly individual instances where we may not want to use that ovary.
Yeah, and I would say the obvious things would be anything that has a high likelihood of malignancy to the ovary. Mm-hmm. So obviously ovarian cancers, we would not even be doing the procedure. Right. Okay.
Our next question is, do I grow more eggs after chemotherapy?
Right. I think we kind of touched on this a little before, but all of the eggs that you have as a female, you have from the time that you're born, right? So if those are there and slowly decreasing over time, you don't have the ability to form more eggs after chemotherapy. So unfortunately, I wish I could come up with that ability, but we don't have that. So what's there is there, and then whatever damage is caused by the chemotherapy is a lasting damage. So there's not a way to regrow those. There's just a way to kind of see what potential you have remaining and try to take advantage of that in the time frame that is allowed. Okay. And then the following is, can I get pregnant while on chemotherapy?
And the answer is yes, in most cases. And you are able to get pregnant while on chemotherapy, and for males, you are potentially able to get your partner pregnant while you are receiving chemotherapy.
I guess we would clarify, you are able, but we would not recommend it.
Yes, that's exactly what I was going to say. It is very difficult to do chemotherapy while pregnant, so we definitely recommend that you do not become pregnant while on chemotherapy.
So this is one of those times where it's very important for us to have conversations about contraception and how important that is during the chemotherapy process, because many of the chemotherapies can cause definite problems, right, to a pregnancy, and then also just that the chemotherapy and the cancer treatment itself, a pregnancy adds a lot of strenuous, problems to the body that's going to make your treatment and your recovery problematic. So, this is a time where it's important to see your gynecologist or your primary care doctor if you're on the male side, to make sure that we're covering those things.
The next question is, someone told me I could receive a shot that would maybe help preserve my fertility. What are they talking about?
Okay. So this is a good question. This is kind of ongoing back and forth for those of us who work in the oncofertility field. But there is a medication that when we talked about those signals that kind of come down from the brain and tell the ovaries what to do, the big long term for those is called the gonadotropins, right? So the thought is that if we could shut those down, and kind of put your ovaries in a fake menopause. If we put you in that fake menopause or in kind of a fake prepubertal state, right, could we make it so that we protect your ovaries from the chemotherapy? And the idea there is that we've seen, so if the girls before puberty or very young girls seem to do better against chemotherapy, if we kind of pretend you're in that state, could we do the same thing? And unfortunately, it doesn't seem that truly pans out for most populations, right? Some studies have shown there's good results and some shown there haven't. It seems that maybe in very specific populations with very specific medicines, usually like a breast cancer population with a certain medicine, there might be a benefit to that. But in the general population, it hasn't really shown that it's helpful. However, we use this same medicine in a large proportion of our patients during their chemotherapy to keep them from having menstrual cycles, because having a menstrual cycle during chemotherapy, number one, just who wants that, right? But for the main reason, it's because we want to keep you from getting your blood counts very low, right? Because the majority of people, if you have heavy bleeding during the time that you're going through chemotherapy, and then you have low blood counts when you're already at risk for that, then it can cause a lot of problems. So if we're already using the medicine anyway for another purpose, and there's a slight possibility that it could help with fertility, then it's not any additional harm. So many patients end up being on the medicine anyway, but for it to be used strictly for the purpose of protecting fertility is not something that we do or that we think is helpful, but it's definitely something that we continue to study, and maybe someday we'll find exactly which populations would benefit from that.
Okay. Our next question is, what about testicular sperm aspiration? When is it best to consider this option?
Okay. So what testicular sperm aspiration is basically if a male is not able to produce a sample through masturbation, then you can use testicular sperm aspiration to retrieve that sample. Okay. So, you could consider those are the times that we would want to do that, right? So if we think that there's a ability to get sperm, but you're not able to produce it, then we can use the testicular sperm aspiration to find that, okay? The other times is sometimes patients may have a very low sperm count, and we may be able to get those couple sperm out of the sperm aspiration where they couldn't produce it through the masturbation sample. So we don't at the moment have that ability here at Children's, but the adult urologists do have those ability in many centers to be able to do that.
And it looks like we're jumping back to females. How many successful pregnancies have resulted from ovarian tissue cryopreservation?
Okay, so at this point in the literature, there's over 50 successful pregnancies that have happened from ovarian tissue cryopreservation. All of these are from the ovary being put back into the body. Usually it's either put back at the the ovary that's left behind. We can take that ovarian tissue, put it back on the remaining ovary, and then the hope is that it would kind of attach to that ovary and gain that blood supply, and you'd start to see the function back. Sometimes we put it back where the ovary used to be, and that same sort of stimulation would occur, right? A couple things on that, though, is that we don't know how many times people have attempted to do this. Because something you'll see is when there's a success, everyone wants to write about it and tell people about it. You don't always necessarily want to tell people about your failures, right? So, we don't know what the underlying number is to that. So when we're telling people about ovarian tissue cryopreservation, I can't give you a percentage of success because we don't know what that is. But we do know that there have been a number of successes and that we continue to see more and more of that. The other caveat is that all but one of these have been in adult women. Some of that reason is that just a lot of the younger girls who have had this done aren't old enough to try for pregnancies yet. So we don't know exactly, how well this will do in our patients who are younger. There has been one case in the literature of a girl who was 13 when she had her ovary removed. So she had already had breast development, so she was partially pubertal, but she hadn't started periods yet. So 10 years later, now 25, has the ovary put back and had a successful pregnancy. So for those of us doing this in pediatrics, this is like a wonderful breakthrough that we're very excited about. But again, it's one patient, and we don't know how many people tried to do this in younger patients and didn't tell anyone about it or didn't write it up in the literature. So, it's that these are the reasons that it's still experimental, and these are the reasons that when we tell people about it, we say we can't say that it's going to succeed, but we can say that, it has been successful in the past. And in many cases, and in our prepubertal girls, unfortunately, it's the only thing that we have to offer. So, if you have the ability to do things like preserving eggs and preserving embryos, that's always the first choice because we know that that works and we know that there's success rates for that. But the ovary is very promising when that option is not there.
Excellent. Our next question looks to be, my daughter had to start urgent therapy due to her Hodgkin's lymphoma. She was told her risk for infertility was low and therefore removing an ovary under an experimental protocol was not recommended. Does my daughter have an opportunity to preserve her fertility after treatment? I worry she will be affected and her fertility timeline may be shortened.
Okay, so I think that's a great question, and we get this question a lot. I agree with the fact that in these low-risk treatments, a lot of times we do not feel that the risk of undergoing this type of surgery outweighs the risk of these low-risk treatments, right? Because, even though undergoing a laparoscopic surgery in most cases is a very low-risk procedure, it is not a no-risk procedure, right? So if your risk of infertility is very low, like it is in most ALL cases, then, this is the recommendation that we would normally give. However, like Karen said, things do change along the timeline, right? And unfortunately, in some cases, if the treatment plan does change and the risk changes down the line, we always come back and have this conversation again. So if a low-risk treatment years later becomes a high-risk treatment, we talk about it again and we offer preservation again, okay? Also, when we see patients in the survivorship program or we see patients a year later and they have had low-risk treatments, but then we do some labs and maybe even though they had a 20% risk of having an infertility problem, but they unfortunately fell in that 20%, then we talk about doing preservation options after the fact. And we still, every option that we talked about beforehand, we talk about again afterwards. So we're still able to offer ovarian tissue cryopreservation, at least at Cincinnati, because everybody's protocols are different, but at least here we're able to offer it after a patient has had chemotherapy. And in patients who are post-pubertal, then we still offer oocyte cryopreservation. Now, some of that's going to be dependent on age, it's going to be dependent on pubertal status, it's going to be dependent on what the patient and the family want. But we do have all those conversations again after the fact. I don't know if you have anything to add to that.
I think that was great. Yeah, absolutely. Our next question is, what are the effects of fertility on female preschooler who underwent standard risk chemotherapy for ALL beginning in 2001? Also, at what age should my daughter seek out GYN care, and does she need to see a specialist due to her previous treatment?
Do you want to answer the first part?
Sure.
Okay.
So, ALL therapy is acute lymphoblastic leukemia therapy, and is traditionally a long course of chemotherapy. So it typically runs for 2.5 years for girls and 3.5 years for boys. So you receive many years of chemotherapy, but overall your total doses of chemotherapy are actually pretty low, especially in terms of your risk for late effects down the line. Infertility is absolutely one of those situations. So there is very little risk, if any, to fertility with ALL therapy, particularly in a preschool aged girl who received chemotherapy when she was prepubertal. So I would say for this particular patient, she would have little to no risk of infertility from her therapy.
Okay. And on that point, as far as when your daughter should seek out GYN care, I think that is going to be a little different depending on your answer to, does she need a specialist with her previous treatment, right? So with the fact, like Karen just said, being a preschool age child when she underwent a very low risk treatment, I do not think that changes her need to seek out GYN care. Because it doesn't change her fertility risks at all, right? Mm-hmm. So standardly, when a child should seek out GYN care is going to depend on if there's any concerns, right? If anybody ever has any problems with vaginal discharge or itching or bleeding, we would always want to see those patients at that time. But aside from those issues, then we normally see girls whenever, they have any problems with, with periods, or if they start becoming sexually active, or any of those concerns. Otherwise, normal adolescent time is a good time to start coming to see the gynecologist. A lot of girls will come about the time that they start having menstrual cycles, so they can have an initial evaluation. And by that, I do not mean you come to the gynecologist and have a pelvic exam. Please do not think that. I mean, you come and you talk about what your anatomy is, what it means to, kind of start your period, how you clean the area, all these things that it means to kind of enter into adolescence. And most girls really kind of appreciate after they're done being mortified what it means to kind of enter into that part of life. So we usually do these basic kind of initial evaluations. And then if girls are doing fine, they don't really need to see us every year as long as they have no problems. Now, if a girl had undergone some type of a high-risk treatment where there was concerns about fertility, then that would be a little bit of a different issue. Girls that are followed in the survivorship program, who we have a concern that they may have a fertility issue in the future, we're trying to begin to maybe see those girls every year and follow their fertility potential if they haven't had some sort of preservation option completed. And then we'll also follow them if they start to have concerns for premature ovarian insufficiency, or basically that's a big fancy term to say if they start to enter into like premature loss of ovarian function or a premature menopause, right? So if there's risks for that, then we want to see those girls earlier and we want to follow them. So it's going to be a case-by-case basis, and we work really closely with the oncologists in the survivorship division to see which girls we need to be seeing when they come into their survivor visits.
Okay. So the next question is, what other disciplines and clinics do you work with? For example, rheumatology and patients taking Cytoxan.
Okay. So this is kind of a fluid answer, I think. So we started out basically just doing oncology patients, and then have kind of worked into doing the bone marrow patients, which includes a lot of the patients with blood diseases. Our goal is to become an all-inclusive fertility preservation program, not just an oncofertility program. So that would involve working with the patients, some, like you mentioned in your question, the rheumatology patients, working with the Turner syndrome group. We hope to be working with the transgender group. There's a large proportion of patients that need fertility preservation counseling, need fertility preservation options. And we are working very, very diligently to make sure that we're covering all of those groups. But currently that is still a work in process. But we're open to any patients who are interested in fertility preservation. We're not turning people away by any means. We're just kind of moving ourselves into all of those waters.
Yeah, I think our service has been growing over the last several years, and our goal is to continue to keep growing. So certainly if there's ever questions out there, we would be more than happy to meet with the family and try to answer those questions.
Yeah.
Okay. The next question is for patients who miss their opportunity at diagnosis. What, if any, options are available? For example, is it possible or advisable to do OTC or TTC after treatment has started, or even when treatment is finished? So OTC being ovarian tissue cryopreservation and TTC being testicular tissue cryopreservation.
Okay. So this is kind of a little what we talked about before, but we'll start with the testicular tissue cryopreservation because both of these, as we said, are on experimental protocols. So both of them are going to depend on where you're asking to get these procedures performed. Because whenever someone is doing an experimental protocol, their protocol has to be approved by their research board at their institution. So there may be differences if you had the procedure done here at Cincinnati Children's versus if you had it done in another hospital. Okay, so I can speak to what we have here. The testicular tissue cryopreservation that we are currently using is through Pittsburgh. There's a very specific protocol of who can and cannot have this done. So right now, patients who can have it done have to have never had a high-risk treatment before. So you can have chemotherapy before, but it cannot have been high risk. And you have to be getting ready to undergo a treatment that is considered high risk. Okay.
And can I just say high risk for fertility?
For fertility,
which
yes,
is different than high risk for cancer staging in general.
Yes, that's a very good clarification. Sorry. Yes. So it has to. You can never have had high risk to fertility before, and you have to be getting ready to undergo high risk to fertility now. So if you fall into those categories, then yes, you can freeze your testicle if you fall into that category. Similarly, on ovarian tissue cryopreservation, here at Cincinnati Children's, we will do ovarian tissue cryopreservation if you've had chemotherapy before, but we have to fit into a certain lab criteria to show that your ovary still does have some function to it. So we do lab testing to show that you're not already in that premature menopause. Because if your ovary already is damaged to the point that you're in premature menopause, we don't want to put you through an unnecessary surgery if your ovary is not going to function for you later when you want to try to use it. So the short answer is yes, but with some caveats. Now, other institutions that are doing ovarian tissue cryopreservation do not allow freezing of the ovary if you've had chemotherapy before. So I think it's important to check with the specific institution if you're not having it done here.
Okay.
Okay, so our next question, if a male sperm banks prior to treatment and then 3 months off of therapy decides to check his fertility status, has a semen analysis performed, semen analysis comes back great, yay, would you recommend tossing the sample he has frozen? Oh, never, never, never. Okay, so how about a good answer?
Yeah, so I think it would be a very great sign that his semen analysis came back looking really good. Because remember, we talked a little bit earlier about for boys, the damage to fertility happens during therapy. So if you have completed your therapy and you have recovered your sperm count, then you're not at risk for future fertility based on your previous therapy. So you could make the argument that you don't necessarily need to continue to save that sperm. I think, yeah, we kind of cringe a little bit because it's hard once you have it to get rid of it then. I think the other thing that we try to have our patients consider, especially only 3 months off therapy, is making sure that you're going to stay in remission, and then you're not going to need future therapy down the line. We don't ever plan on someone's cancer coming back really, but we still like to take precautions. And I think at 3 months off therapy, I would try to encourage somebody to hold on to it at least a little bit longer and think about it a little bit longer. However, that said, their fertility is fine, so the risk from the therapy they already received is really not going to come into play. They got through it with good fertility.
Okay. And the follow-up question that is, how long can sperm be frozen? And I would say once you have your sperm cryopreserved, it can be cryopreserved and stored in the storage facility for as long as you need it to be there. So, and that's the same with all of the techniques that we're cryopreserving. So if you have eggs, ovaries, testicular tissue, any of this that's frozen, once it's frozen, it can stay there. So, you know, some people who we come to talk to them about fertility for their 1 month old, or that is a very, you know, kind of awkward conversation for you, that we understand that you just had a baby and we're talking about that baby's fertility, right? You know, they might not need that tissue for 25, 30 years. It can be frozen for that long. So, you know, rest assured. And the facilities that these tissues are frozen in are, you know, they have backup generators. They're like ready for tornado proof, and they send all kinds of things to say how protected they are. So they should be very well kept. I think we did that question. Sorry.
We're looking for our next question here. Okay. Could it be possible for a female baby who had a bone marrow transplant for leukemia at the age of 11 months to one day have children? It is technically possible that could happen. There are certainly case reports in the literature of females in particular who were very young at the time of their bone marrow transplant, who were able to conceive and have children as they grew older later in life. The risk, remember, is for early menopause, and the younger you are as a female when you get your therapy, the more protected your ovaries are, and so the greater your chance that you may be able to get through intense chemotherapy like a bone marrow transplant and still be able to have children down the line. It would be the exception. I think for the most part that therapy is extremely intense. So even for young children and young girls, the risk of infertility is still extremely high, but it has been reported. I think the best thing to do is to continue follow-up and continue monitoring as this child gets older and goes through puberty. We have some lab markers that we talked about earlier that we are able to follow now, like the AMH, that may be able to help us try to determine what that window may be and if there's going to be one present.
Yeah. And I think one thing I've learned as a gynecologist is never to tell anyone that they can't get pregnant, because that will come back to not be true, right? But it definitely, you know, when we talk about risk, we always say greater than 80%, because you can never tell anyone 100%, right? There's always going to be that chance.
Never say never.
Yeah, you never say never, because even people who are in complete ovarian insufficiency, we now call it insufficiency instead of failure, because there's always that, you know, 5% chance that you could ovulate now and then. And, you know, if things aligned at the right time and you hit those ovulations, then sure, there's always a chance, but it's going to be a very low chance. And there's going to be more of a chance that the fertility is going to be highly damaged. So, you know, we are more here to say, you know, we want to let you know what the risks are, and if you have an interest in talking about possibilities for preservation, then we want to make sure that it's offered to you. But by no means do we say that everyone has to take a preservation option, right? There are plenty of patients who say, you know, I want to just, I'm glad that you came to talk about it. I'm glad that I know now what the risks are. And I've made the decision to not do this option, and we'll see what happens when it happens. And I think the important thing is that you're putting that in the ballpark for the patient to make the decision, and then see what happens in the future. So we have another question. Are all of the fertility preservation options offered at your institution actually performed at Children's? Which I think we touched on a little, but I think this is important. So the only thing that we actually perform here in the hospital itself is the ovarian tissue cryopreservation. The sperm cryopreservation and the eggs and the embryos are worked with our adult partners at the University of Cincinnati. Because these go through the reproductive endocrinologist. So we discuss the procedures here. We do collect some of the semen analyses for patients who cannot leave the hospital. So that is available if patients are in the hospital and they're too sick to leave. We do collect in the hospital, but most patients will go to the University of Cincinnati to have those collected. And we work closely with our partners there to have that done. And then for the testicular tissue cryopreservation, we're currently working through the University of Pittsburgh for patients to have that procedure performed. But we are working with our institutional review board or our research board to be able to have that offered hopefully in the next couple months to a year.
Okay. And our next question is, what is your AMH cutoff for eligibility?
So we actually do not have an AMH cutoff for eligibility, mainly because the AMH is still too new for us to feel like we can use that as a cutoff. The cutoff that we use for eligibility for ovarian tissue cryopreservation is just based on FSH, and that number is 20, correct? Yes, thank you. So we are currently using just the FSH of 20 that is recommended from the Oncofertility Consortium. And we basically use the anti-Müllerian hormone for us to help educate and counsel the patients. But we're not using it as a strict guideline to say that patients cannot have the procedure.
Okay. Our next question is, what does follow-up look like for someone who did have ovarian tissue cryopreservation and study follow-up?
Okay. So as far as the study follow-up, we try to make sure the study follow-up is that we call patients once a year to do follow-up surveys. At this point, we have not been as good about doing that as we hope. So for those of you on the line who have had ovarian tissue cryopreservation and you're like, where's my phone call? We are getting to you, we promise. But for the future, that will be the follow-up, is that our attempt is to call every year to basically do follow-up questions, to ask, about your future fertility, to ask some questions about, menstrual cycles and these type of things that would be important to the study, as well as to make sure we know, where you are, basic demographics of how you're doing. And also, we're hoping that each year we can call and give the patients an update of where the research is, right? Because you give us your ovary, you want to know what is going on with the research and if you're going to be able to use it someday, right? As far as medical follow-up, there's nothing really that's required from a medical standpoint for your follow-up that's any different from your basic follow-up for your oncologic diagnosis, or the follow-up that we would want to see, based on your fertility risk in general.
Okay. So I think at this point we have reached the 8 o'clock hour, so we would really like to thank everyone for joining us and for sending us all of your great questions. We hope that we were able to provide some valuable information, and we would be happy to answer more questions if you guys would like to call the number provided on the site, or be able to get in touch with us through the website. And we would be happy to try to provide the information.